Hello, and thank you for joining me today for Big Ideas in Eating Disorders. In this series, we hear from people in the field of eating disorders who share with us their personal and professional journeys, experiences, reflections, and big ideas that never quite get represented this way in standard academic publications and conferences. I'm Kathy Pike, clinical psychologist and professor at Columbia University. I'm the host of Big Ideas in Eating Disorders, and today I'm delighted to be joined by Dr. Michael Devlin. Dr. Devlin is professor of psychiatry at Columbia University Irving Medical Center and also a past president of the Academy for Eating Disorders. Dr. Devlin has extensive experience across a range of eating disorders research and treatment, and especially the area of binge eating disorder. We're delighted to have you join us today, Mike.
Thanks, Kathy. Happy to be here.
Great. Thanks for being here. Let's start at the beginning with just growing up years. And when was it that you came to imagine that you would become a psychiatrist?
Oh, gosh. I was always interested in the mind and the brain, I think. It's interesting that where I went, this small Catholic high school that I attended, we had to write a term paper on any topic in the world, and I chose behavior therapy. And so it was just out of
how old were you at that point?
I was like 17, something like that. And I just thought that was like the most interesting thing to learn about. So I did. And then it's funny that I ended up in psychiatry because I wasn't really planning on that at that stage. And then even more unexpectedly, that CBT ended up being something that I was kind of drawn to and ended up, teaching and supervising. So it's just funny how that worked out. My dad was not a psychiatrist, but he worked here at the medical center where I still work, and he worked in the Department of Psychiatry as an administrator. But, because of that, I heard a lot about psychiatry and psychiatrists at the dinner table. And certainly my family had a lot of respect for psychiatry. So I have to think that maybe that played a part in it too. But the great thing with med school is that you get to try everything and pick what you like the best. Psychiatry was just the most interesting and rewarding for me.
So when you were in med school and then doing your rotations, where did you first get exposed to psychiatry?
We had a little bit of kind of classroom-ish psychiatry in the first 2 years, but the first practical experience was in my third year rotation, which, as I recall, was mostly doing sort of outpatient work and evaluations and that sort of thing, and getting supervision on those and really getting excited. And then I did an inpatient rotation on this unit called Neuro 12, which was run by Stuart Udofsky and Eric Marcus, names you might remember. And that was this really wonderful kind of multidisciplinary, super collaborative, multimodal, but with a very strong psychotherapy component. And that really sold me.
So you did your medical school training and residency at Columbia?
Yeah, I got away for 1 year. At that time, you would typically do a year of medicine and then start psychiatry and PGY 2. So I did my year of medicine at Lenox Hill Hospital all the way to the east side.
Right. On the other side of the park.
Yeah.
So you've been at Columbia for a long stretch. Over this time, what observations have you had about behavioral health, about healthcare generally, that have informed your practice?
I mean, I feel like behavioral health is much more sort of in the mainstream. There was always, when I was going to medical school and training, a little bit of a sense of like, if you went into psychiatry, how come you didn't become a real doctor? And that, I think it's kind of all but disappeared. And there's a lot of interest almost every year among our medical students in psychiatry. Because psychiatry really has advanced so much in terms of how we understand, even though we still have such a long way to go, and we're still in sort of fundamentally the same nosology, even though there's lots of, ideas for alternative nosologies and more mechanistic based nosologies, but it's a work in it's a work in progress, but I think it really has evolved quite a bit.
And the integration of behavioral health, of psychiatry across other areas of specialization seems to me to have expanded dramatically.
Very much so. Yep.
Yeah. So it's, as you said, it made the comment that why didn't you become a real doctor, if you became a psychiatrist? When you said it, I remember that, but it does feel like that's something, a blast from the past.
Yeah, it is, I think, happily,
Yeah.
Because that was really, that actually sort of gets into the whole, the big idea of kind of how we talk about things is how we think ends up, influencing so much how we think about things. Because, when that was kind of the prevailing ideology that somehow psychiatry was like off on the side, it really, I think it's very limiting, and as we've moved away from that, it really opens up a lot of vistas.
You said it was a unit that really was generative in terms of ideas and embraced a model of integration around science and practice and teaching. Right. So was that unusual? Was that not the case in other areas, or was it just especially pronounced on this unit?
I think it was very pronounced on this unit. One thing that was very special about this unit was the interprofessional, and interprofessional education is something that I've been very involved in my more recent career, but where there was really a respect for like rounds where, the nurses and the social workers and the therapy aides and really everybody was on a level play. And in many ways, what the therapy aides had to say was taken, like that was the most, the sense was that they had really the most valuable information because they were really out there with the patients and and so that really encouraged folks to be really thoughtful in terms of their observations. And people were so valued, and everybody kind of knew each other, and there was like the big cookout that everybody went to. So it really was one of the best models of interprofessional care that I've ever been involved with. And that was, I don't know how many years, a lot of years ago, right? Like 40 something years ago, I think.
Yeah. So the push today for interprofessional care and teams and cross-functional teams is new and old at the same time.
It really is. And I think, at the time that it was much more, particularly coming from the MDs, much more transactional, like we need this from the social worker, we need that from the nurse. And there's still a lot of that, I think we're pushing forward, but it's really through, embracing interprofessional education, like not like right now we have, all of the health sciences students are involved in interprofessional education, some more than others, with the idea that you need to like grow up understanding who these other people are and what they're contributing and valuing them as really equal members. Medicine is notoriously hierarchical, and that's so problematic.
Yeah. So you're on Neuro 12. It's not an eating disorders unit. So how did you get to eating disorders?
How did I get to eating disorders? So I did my year of medicine, and I was very happy to have done that, but also to be done with it. And then I landed on July 1st of 1983 on the old PI7, where the attendings were Steve Roos and Tim Walsh, and got to work with that patient population, got to work with Tim, and just thought, wow, this is so interesting that these folks that are kind of medically interesting and genetically interesting, and the family stuff is interesting, and the psychotherapy is interesting, and the pharmacotherapy to some degree was like beginning to be looked into. And it just felt like, there was something about behavioral disorders of like the mind, kind of in conflict with itself in that very concrete way, whether it's something that's the person is clearly like sort of not wanting to do, like binging and purging, or something that they're so ambivalent about, like restricting. It just was so interesting to kind of try to understand and help with that.
And early in the field, 1983,
yeah,
we're early on, and really just beginning to recognize bulimia nervosa
Was a new thing
DSM.
at that time, and binge eating disorder was years away.
Right.
Yeah.
So it was a new field, essentially.
Yeah.
Right. And the excitement and the energy and the intellectual and professional heart of trying to figure this out, as you say, and contribute to understanding must have been really exciting.
It really was. Yeah.
Yeah.
Yeah. I feel lucky in some ways to have come along when I did, though I think probably anybody could say the same, because it's always exciting. You know, there are many more opportunities for people who are just starting out now. There's so much more, you know, understood. There's so much more. There's so many more ways that one can study people with eating disorders.
Yeah. As you started your work on the inpatient unit with Dr. Walsh, who was your mentor and mine, and began on a clinical research unit, that's also a really interesting thing about the service that you were on, because it was a place where research and clinical care are intimately linked. How did you get started? Was there a particular study that you started with, or a particular program?
I don't think that I did. I got so involved in research when I was at PGY2. That didn't really happen until probably when I was at PGY4 and kind of deciding that I was going to do the T32 research fellowship with Tim. And then I did half with Tim and half in developmental psychobiology with Myron Hofer and that group. And then really, you know, initially got involved with, so Tim was like not that many years away from when he was a fellow, and he had done a lot of work in endocrinology of people with eating disorders, and had a lot of data that he had never really had the opportunity to. And so, of course, like for a resident or a new fellow, that's ideal to have like a nice data set that you can jump into. So that was some of my early work, was following up on that, doing a lit review on the, you know, neuroendocrinology of I think anorexia in particular, but maybe eating disorders in general, and then analyzing some of Tim's hormonal data on the hypothalamic pituitary ovarian axis, and got it, you know, a nice paper out of that. And then, you know, at that initially, Tim was most involved in medication studies, so helping out with some of those, getting a little bit interested in kind of comorbidity with depression. And then a big kind of shift came when Tim, in the course of his work on DSM-4, met Terry Wilson, who was doing CBT, and then Tim and Terry decided, wouldn't it be interesting to do a study that involved both medication and CBT? And then the question came up, who was going to be the therapist? And I raised my hand and said, I'd love to be trained in CBT. And so that happened.
And then I joined you.
And then you joined. Yeah.
And what a great chapter that was.
Yeah.
So the work that you were doing in those years focused on clinical trials, CBT and medication. We worked around bulimia with a focus on bulimia nervosa, then anorexia nervosa, and then you started leading some work on binge eating disorder.
Yeah.
So tell us how that emerged.
So that's interesting. And that, again, it sort of gets into the big idea a little bit, was that there, you know, we were getting a lot of calls from folks who had a problem with uncontrolled eating, like very clearly, you know, and would have met criteria for bulimia nervosa, except they didn't do anything to compensate either purging or non-purging. And, you know, we asked that question that I think we ask all too rarely, which is like, are we missing something here? You know, because that's always a good question, because the answer is always yes. You know, and so we were, and then, you know, had the great good fortune to hook up with Bob Spitzer, who himself was also thinking, I think independent of us, as he was starting to think about how psychiatric nosology was looking forward and was looking for like things that really ought to be codified as diagnoses, but hadn't been yet. He really leapt into binge eating as, at least to his, and he's a guy who's thought a lot about this. So that carried a lot of weight, that Bob thought that this was something that was worthy of attention and that might be a real thing. And so Bob, in his Bob-like way, reached out to so many eating disorder people, and then also folks in the obesity world who up to that point had almost never met one another to a large degree. And it also just got a lot of like people. He had an associate at that time who themselves had some experience with binge eating and had a real kind of first person lived experience interest in this. And so they helped out a lot. And just like getting people in who wanted to talk about this and wanted to talk about their experience and help in any way, because they felt like finally somebody's noticing, and not just somebody, but Bob Spitzer,
right.
Who's in a position to do something about it.
Right.
And it was, it really started to take off and come together.
So Bob Spitzer was really a leading force around diagnosis, around classification, leading the DSM-3 and 3R. He now is working more broadly across disorders as a scientist, saying, what have we missed? What do we need to add when we think about bringing or evolving the nosology for DSM-4, and brought all these people together around this phenomenon of binge eating.
Mm-hmm.
And any particular meetings that you remember from that time? Any particular decision points that were critical?
Great question. There was the gradual development of what ended up becoming the QEWP that Suyanowski took the lead on, and she was certainly like one of the core early people in this whole effort. But that was something that just evolved, it started small and just kind of evolved over time.
Yeah.
I just remember like a lot of meetings with folks from, some of the local OA chapters who just wanted to come up and like hang out in Bill's office and in Bob's office and, talk about what they were experiencing.
Right. So in an interesting way, what you're describing is a practice where people with lived experience really contributed meaningfully.
Yeah, they really did.
In terms of
absolutely
understanding what this phenomenon was.
Mm-hmm.
So in that work, eventually binge eating becomes binge eating disorder, or when binge eating passes a certain threshold and meets a range of criteria, it becomes binge eating disorder. And it matters that it goes from binge eating to binge eating disorder, right? And so I wonder, that makes me think that we should move into this idea of yours that really is about, it matters how the language we use matters.
Yeah, that's the big idea. It's a very big idea. And it's obviously not original to me. Many people have, thought this and written about it, but it certainly has been an idea that has echoed throughout my career. So that's why I picked it, that how we talk about things really influences how we think about them. And the second part to that is that, and we sort of are not even aware sometimes to the degree to which that is happening. So once we've decided on a way of talking about something, we really go down a certain road in terms of how we think about it. And so, back when binge eating was binge eating, there was, I think, a lot of thought about almost a kind of moralistic thinking about it, that this was a sort of a weakness. This is people not exerting control where they should be. There was also a sense, I remember a lot, I had the opportunity to sit in on the DSM-4 meetings, and I think it was the DSM-4, yeah. And that people thinking like, oh yeah, like sometimes I will have the whole pint of Ben and Jerry's and I didn't mean to. So do I have binge eating disorder? Like people kind of poo-pooed it, initially. Um, it's because it wasn't really thought of as, this is not really an illness. This is just like some kind of bad habit, weakness kind of thing. But, when it became clear, it's like, no, this is not somebody who occasionally eats a pint of Ben and Jerry's. This is something, and we got that through the lived experience. Like it was, people saying like, I've had problems with alcohol. I've had problems with cocaine. This is worse. Like this is a really big thing, and it's something that infuses every aspect of the person's life. Often on a daily, pretty much always on a daily basis in one way or another, whether or not they're binging on a particular day. That it became clear, well, no, this is an illness. It's much more, like bulimia or even anorexia than it is like some occasional thing that you do that you shouldn't have done. And so I think that really made life a lot better for people with binge eating disorder in terms of being able to be taken seriously, not be blamed, be offered treatment. It didn't magically solve everything, but at least, and then of course there were other factors, not just in terms of how we think about it, but how we reimburse treatment and all that sort of thing that come about. But I think a big part of it is also simply how the world thinks about it and sees it.
And so the act of naming something shapes, as you're saying, how we think about it, then what we do about it. And it also impacts how we feel about it, right? So, and certainly in the case of binge eating disorder, one of the things that's complicated, or that I can say it, or I guess I should really ask it as a question. Let me ask the question. With binge eating disorder, it seems to me that one of the challenges is this intersection among the group of people who seek treatment for binge eating disorder. They are often also at a higher body mass, a higher weight status, right? So you have the condition of a behavioral disorder and this physical condition. And what does that mean in terms of naming something? And how does that contribute to this idea of naming something and the complexities around that?
So that gets into the kind of a whole other area that I wanted to get into. Which is obesity and obesity treatment and what that means. And really what that was sparked by was, what has seemed to be kind of a polarization between the health at every size movement and the kind of, obesity as a medical condition that needs to be treated movement, and, trying to understand how names matter there, and how naming something as a disorder or providing treatment for it can actually affect how we think about it and have an impact on people who have it. So I just need to take a little sidestep now into my own personal story, which is kind of, I think, what got me thinking about this is that growing up as a gay person, a gay man, at the time that I was growing up, there was reparative therapy, which is sort of something like that term right there. Reparative means like you need to be repaired, i.e. you're broken, which is not something that feels very good to a person. And at the time, actually, homosexuality was defined as a psychiatric disorder, and that also changed. In large part through, again, Bob Spitzer comes into that story as well. It occurred to me that that's something that's core to my identity, and somebody else is saying, well, we have treatment for that. That feels hurtful to me. So obesity, while medical people may think of it as kind of adiposity, or they may think of it as certain sorts of metabolic features or metabolic risks, in common parlance, obesity means your body, right? Obesity means you have a body that looks kind of large and round or whatever, or you have your face looks a certain way, your body looks a certain way. That's what obesity means, I think, in popular language. And so to then say, like, we have treatment for that, sort of is tantamount to saying, like, your body is not right. It needs to be the focus of treatment. And certainly that message has gotten through, right? Like, just talk to, so many people who I've talked to over the years, have lived that, and have internalized it, and have absolutely felt that my body is not right. And I want to do anything that I can to change it.
Mm-hmm.
And just a world of grief has come out of that. I don't have to tell you. It's that's, and so I feel like maybe I can understand. I don't know, somebody else might disagree with me, but having been in that position of something that's part of my identity, being stigmatized, and at one time anyway, being a target of treatment, I feel like I get that a little bit, and I get how undermining that is. But I wonder a little bit, and maybe you think I'm crazy, but that whether the term obesity is just too problematic. It's just so loaded with what it means to, in the common mind and the common imagination. Because what I think is absolutely, if somebody has metabolic problems or is risk for metabolic, we 100% we should address that. We would be remiss not to. But maybe we don't have to call it obesity treatment. Maybe we don't have to call it weight loss treatment.
It's very interesting that you say that, Mike, because as you know, I lived in Japan for almost 12 years, and the rates of higher BMI or rates of obesity are very low in Japan, but increasing. And in Japan, the Japanese healthcare system is alarmed by the increases in population weight because of the healthcare implications. And even though the rates are much, 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 much lower than in the United States or most of Western populations. But what Japan did is focus on what they call metabolic syndrome.
Yeah.
And they thought what the healthcare system needs to focus on are the healthcare issues. And honestly, when they first launched this program, I thought, why don't they just call it obesity? Like, that's what everyone else calls it. But actually, I think it was brilliant because they were really focused on what the healthcare system really needs to focus on, which were the health implications of a certain status, a certain clinical status. And it wasn't about what your body shape looked like. It was what are your health markers.
Yeah,
it's really interesting to me.
I think it's a great way to approach it.
So would it be different in your view if let's just say within the eating disorders world, if we talked about metabolic syndrome rather than obesity?
Yeah. And I think
what would that mean?
I think what that would mean with that, you would say to somebody, like, you're having these metabolic problems or metabolic risks, we want to, treat those. Your body might change, but that's a side effect. It's not the point of treatment. It's to change your body. You might like that side effect. You might not like that side effect, but it's a side effect, Now, like, again, there are some situations where it is the mass of the body or the size of the body that is the problem, and that might have to be targeted more. But that tends to be, I think, in more sort of extreme situations. Now, like, you might say, like, that's all nice for you to say that, but come on, like, we live in the real world and people just want to lose weight, like people, but I think it's because they're saturated in the ideology that we've all grown up with, and they've reacted to it. In many cases, people internalize it, and people have drunk the Kool-Aid.
Right. So when you said we live in a world that emphasizes thinness and promotes thinness. And that has certain implications. In reality, also, we know that higher weight status, BMI, is associated with significant health implications, metabolic and other health implications, like diabetes, for example.
Yeah.
So are we skirting the issue by saying that weight doesn't matter?
I don't think so. And again, I think if, weight is a marker, fine, it's a marker. If that's an easy way to kind of identify folks who might benefit from screening or whatever, okay, but that's all it is. It's not, it's so easy for it to slip into like weight is the problem itself. And that, I think that slippage has created just tremendous problems and stigma and has been incredibly destructive to so many people. And I feel like we need, just going back to my own experiences as a gay person, like we have Pride Month now, we just had the Pride March yesterday. I feel like we need Body Pride Month at some point. That's even maybe more than we need LGBTQ Pride at this point, because that's become much more accepted, at least in this part of the country.
Yeah.
And I think, when I say that, I can just hear people saying, but like, that's a horrible idea. Like then you're promoting illness. And I'm not saying that at all. I'm saying I'm promoting body acceptance. I think you can be 100% for health and 100% for body acceptance. I don't see those as, warring principles. I think all of that is health.
Okay. So you're focused in this big idea around language and language, how language shapes how we think about things, how we feel about things. What you just inserted, this idea of body acceptance, what does that language mean?
That it's okay to have a larger, rounder body, and like, there's nothing inherently wrong with that or any other body type. That's a beautiful body type, like many others. Like, should you be concerned about health? Absolutely, you should be concerned about your health. Should you be, monitoring your your insulin sensitivity and your blood pressure? Sure. If at some point should you be getting treatment for metabo, if you have it? Sure. If your body changes, what about that? Well, that would be tough. Then you have to kind of deal with that, but that wouldn't be the point of it. That would be something to grapple with. And there could even be a trade-off of to say, like, my body, it is worth it to me. Like my body is enough of my identity that I'm willing to take this risk. People do that in lots of other areas of life. People like live in places where the air quality is not the best, etc.
So going back to this big idea around language and how important language is in how we describe and define what a condition is, what a disorder is. As you look ahead for the world of eating disorders, what are the conditions or where do you see this issue of language being especially critical at the moment?
So the other example that came up for me recently, just in my reading and discussing, is the whole idea of terminal anorexia, which has gotten a lot of attention recently. And and I think that's in many ways that's all about that term terminal, which actually I looked up a little bit, an article on what is terminal even, like without anorexia, what is just the word, is the word terminal even well defined? Like terminal anything? It's not. Like people mean different things by that. There's a kind of a general sense that it means you're probably going to die from it and you're near the end of your life, but it's not well defined at all. But what was interesting to me in thinking about that in terms of this idea was that I think the folks who proposed the term and, proposed kind of what would be criteria for that were really very aware of like that how we talk about things is going to impact how we think about them. And that would really open the door to things like medical assistance in dying and stuff like that. And have us kind of thinking about that in a much more open way. And I think Angela Guarda, who wrote that very powerful editorial opposing it, like absolutely understood that. And, that her title was, let me see if I can find it, but it was something like the terminal anorexia cannot and should not be defined. So she focused exactly on what, in my view, in the right place, which was on the term itself, with the idea that once we kind of let this term, it feels like a sort of an academic discussion. Let's just come up with this new term and a definition for it. And again, I think the folks who were proposing it were doing it out of all compassion and all good reasons and wanting to make the world a better place. So I don't condemn that, but I think it was all about, very much about, if we have this new term, it's going to really change how people think. And, the folks who have been opposed to it have said, like, we don't want to change the way that we think about this, that's dangerous. And like, let's slow down a little bit. And we definitely don't want to start introducing new, terms that are going to then become a kind of shortcut to things that should not have a shortcut.
Mm-hmm. And as you say, once you somehow define this condition, which Dr. Guarda is saying we should not define because we don't have enough information to actually viably define.
Right. And we didn't even, and I would add, like, we didn't even know what terminal means in any other context. So let alone anorexia.
Yeah.
Yeah.
And it creates, because as you say, the language we use shapes how we think. It gives us a false sense of confidence that we know something that we don't actually know. I
think that's the point. Yeah.
You talk about this big idea of language and across the history of eating disorders, right? Defining disorders, defining bulimia nervosa. Once we describe the disorder of bulimia nervosa, discovering that we're leaving a large group out that's binge eating, but not compensating. So defining binge eating disorder. Now there in the field is this new debate of language around terminal anorexia nervosa. The way we define things and label things, right? It takes us to kind of, diagnosis is a specific form of labeling theory.
Absolutely. Right? Yep.
And or labeling theory applies to the world of diagnosis in a specific way.
That's so interesting that you bring that up. I took a sociology course in college about that.
Yeah.
And I remember it's kind of an interesting and sad story. My grandmother was becoming demented at the time. And, but it was like really in the early stages and you couldn't quite tell. And so like, she thought that my, that my aunt was who lived with her was behaving in strange ways. And my aunt was saying that she was behaving in strange ways. And I was like, I adored my grandmother. So I kind of wrote this whole term paper on, dementia and labeling theory and how once you label somebody as dementia, they started. And then, which was, I thought, a pretty good paper, but then it became like clear that she really was demented, unfortunately. Yeah.
Yeah. And sometimes having the right label, to your point around language, having the right label, having the right diagnosis can be profoundly constructive and helpful. People understand their condition differently. They can access care differently. They can remove some of the burden of self-blame and self-loathing by understanding that this is a phenomenon that is shared by many others.
Yeah.
So it can have many and varied implications. Yeah.
Absolutely. Yep.
As you look forward to the next generations of professionals, whether they're researchers, clinicians, and individuals with lived experience in the field of eating disorders, what might you say about how to think about this issue of language?
I think I just want to go back to that that sort of initial question of like, what are we not seeing? What are we missing? What might we be assuming when we talk about things the way that we talk about them? Can we take a step back? I loved your like the kind of cross-cultural comparison that you made with like Japan. Like that's a very eye-opening thing. I sometimes think about, remember how Kelly Vatusek back in the 90s would talk about things that sounded a lot like anorexia, like elite climbers, or like if somebody came and took away your baby, and those kinds of things that, you know, that were a lot like the experience of anorexia, but without the label. And it was totally eye-opening to anybody who ever heard her. Like that we could do more of that, you know, just of trying to remember to question the labels
and
see what we're not, think about what we're not seeing.
Pull the curtain back on what assumptions we're making, what we're not seeing. Yeah. In terms of mentors and people who influence the way you think about things, and the ongoing, the future history of eating disorders, thoughts, and you spend so much time as an educator, Mike, in preparing the next generation of health providers. What do you think matters most in this experience of generation to generation learning and questioning?
Yeah. I mean, I think always, you know, always, and this is something that we're much better about than we used to be for sure, but kind of a note that we started out on is the value of lived experience, you know, of really understanding from the point of view of the person what it is that they're experiencing, and just really understanding how crucial that is. And it's so easy to think we understand everything as a psychologist or a psychiatrist or a physician or whatever. And you know, I've never not learned something. I talked to somebody about their lived experience.
Yeah. And even that, right, when we think about language that we use and legitimizing somebody's experience, the term person with lived experience is something that is a legitimizing use of language that's relatively new compared to the way that the healthcare professionals would historically think about whether somebody could contribute to understanding.
And physicians need it the most, I think, having traditionally been at the top of the hierarchy.
Yeah. So any last comments, thoughts that you'd like to share as we wrap up today?
Not really, other than that it was so fun to talk about this with you in particular, because like I feel like we together were able to generate some interesting ideas maybe.
Great.
So I look forward to continuing the conversation.
Thank you so much, Mike. You've contributed so much with your generous spirit and your capacity to continue to look and question and step back and evolve your thinking. And I know from my own personal experience of learning with you and from all of the students who have studied with you that you have so much to share and have really helped us all grow in the field. So thank you.
Thank you. Thanks, Kathy.